Today we'll be placing 6 implants in the mandible on our patient Gary, 70-year-old male, healthy, no contraindications. Today we've chosen to use the Smart Implant system, a system which I've helped develop, but it is a CAT scan surgical guided and immediate load bridge system. There's a lot of good systems out there for the CAT scan information, Astra, Keystone, Noble Biocare, iDent. However, today we're going to be using the CT information that was used in Materialize, in Simplant planning, and then a Smart Implants fixed bridge to be placed on the implants later today. Here's Gary's ridge as it presents 4 months post-extraction, and we'll be putting in 6 implants, guided surgery. This is the Smart Surgical Guide. We have the areas labeled to correspond with the instructions and color-coded to correspond with the implant size, position, and depth. We'll try this in before we get the patient numb to ensure good fit. The surgical guide is clear so that we can see the blanching underneath, and the blanching ensures, again, a good solid fit. We also want to try in pre-surgery the bridge and the bridge carrier. This is the Smart Implant bridge and bridge carrier, where it comes apart, and the bridge and the denture docking system, once the bridge is put in the mouth, comes apart. And this will be the bridge that we put in today. This is the final prosthesis. This is the carrier, and it'll be discarded later after use. So we want to try this in and make sure that the fits as good as the original denture did. Okay, Gary, go ahead and bite together. And there's his occlusion, and because there's some give in this, as he bites together, that bridge will balance right up into a balanced occlusion against that upper denture, which is actually also a implant smart bridge that's already in the mouth. Okay, open. So everything's fitting good, so we're ready to go. Okay, we're back. Gary is now numb, and we're ready to begin. We'll take the surgical guide and place it in, and because this is a flapless surgery, we're not going to lay a flap today, but we do need to remove the gingiva that's in the direct path of the osteotomies. And we will do that by hand placing the surgical guide and using a tissue punch which fits down through the surgical sleeves, and we'll just mark the tissue. That's all I'm doing. It's not important at this stage to remove the tissue tag, but only to mark the tissue, so that once I remove the surgical guide, I can then remove the tissue tags. Our game plan for today is placing these 6 mandibular implants. We're going to have 4 of them in front of the middle foramen, and then we have 2 distal in the middle foramen. Again, because of our guided CT planning, we know that we're staying at all times at least 2.5 millimeters away from the nerve, and we know what bone is hard and soft, and how far we need to go with each step, all due to the pre-planning. What you can see here is just the tissue tags are now marked and are ready to be removed, and once those are out, then we'll be able to prepare the bone for the implants. We want to remove these tissue tags just to ensure that we don't pull any of the tissue down into the osteotomy. We want to keep those sites real clean, and so it's important to remove this tissue. Okay, we've now removed all the tissue tags. That's important so we don't pull them down into the osteotomies as we go. And here we are with the tags removed. And things look good and ready to move forward to the next step. We'll now be placing the surgical guide. This time we'll be placing the surgical guide with the fixation screws to hold it in place and ensure our accuracy. Here is the initial drill that we'll use for setting the fixation screws. It'll go through our 2mm guide tubes here, and the length is appropriate and pre-planned according to our CT scan. So we know we're not going out the back of the mandible, we know we're not going too far, too deep, and that we're also not in the way of our implants. So we'll set and hold secure the surgical guide, and then Joe, if you could hold his lip down right over that front one. Okay, watch his lip. Here's the fixation screw. We've already prepared the bone for it. The screws aren't very big, and they don't get to grab the bone very hard, and so we certainly don't want to over prepare our sites, as we want these to bite a little into the bone and give us good support. Typically we have 4 or even 5 fixation screw positions planned. However, we usually only use 3. The extras are in case we do get into bone that's too soft, or if we over prepare the site and we get a loose screw, then we can use a backup site. So we'll use 3 of the 5 prepared sites here today. I like to use this drill to punch through the cortical plate, and depending on what I know about the CT scan and what we've seen, oftentimes that's enough. Again, as the screw is real small and the bone is usually fairly soft, especially in the maxilla, we don't want to lose that bone bite. We have all 3 of our first 3 set screws in. They all went in very nicely. They all had good grab in the bone. They're holding our surgical guide in position nicely. We can see the blanching through the clear surgical guide. We know we're in good position. We really have no need for the other 2 screws. If one of these had been loose or spun or was not giving us the stability we needed, then we can come back and grab these last positions. We can also look down through the surgical guide and see that our tissue punch holes are properly lined up. Things look good and we're ready to go. Okay, with our guide in place, we're now ready to go into our drill sequence. We're going to start with a 2mm to start our osteotomy and get through the cortical plate. This first step is a guided. We have our 2mm drill guide here and our 2mm drill. These slide right into the surgical guide, and based on how the measurements are made, you want to be sure that the surgical drill guide is all the way down flush against the surgical guide. Once that's in place, then we just go, again, we know the depth of each drill, if it's to go how far before it stops. This is all pre-measured on the CT scan and is part of the drills that we use with the system. And because of that, we just drill down to final length. We have our sterile irrigation and external sterile. And we're going to keep our drill speed between 800 and 1200. And we'll even take our saline solution and store it in the refrigerator so that as it comes out, it's quite a bit cooler than room temperature. Sometimes in the posterior region, our drills are too long to fit. You can take the drill and the drill guide and put the drill into the drill guide before fitting it down into the hole. Then just still be sure that that guide slips down all the way, and that buys us some extra space. Okay, we've completed the 2 millimeter initial osteotomy. Now we simply step up through a series of drills. After the initial 2.0 drill, we step up to a 2.3 drill, and the 2.3 drill, of course, corresponds to the 2.3 guide. We have a long and a short. In this case, with Gary, back here on our distal most implants, because we know we have that IA canal that we're being careful of, these two are considered short, and that's all been pre-measured and pre-planned on the CT scan. So even though I'll still be able to go completely to length, I know that I'm, according to my plan on the CT scan, I'm still 2.5 millimeters away from the IA. So I get my drill guide set all the way down to the surgical guide in the mouth, and then we just go to depth. We're going to come over to this side because the only two short ones are in the back, and so I'll do the two short ones first all the way to completion, and then I'll switch to a long drill to do the front. Next is our 3.0 short. The blue represents a 4 millimeter implant, so we're going to go to depth here with our 3.0, and then we'll take one more step up, stopping just short of our 4.0 diameter. And our final short drill is a 3.25. We've talked a lot about length. Obviously, because of the fit of the drill guide into the surgical guide here, we also know where we are angulation-wise as well. Now, even though we know our angulation, and it's all guided. There's still error to be expected from, say, a right-handed operator who's going to lean on one side of the drill or the other, or placement of the surgical guide could be pressed down 1/10 of a millimeter more or off to one side or the other compared to where it was when the patient was biting in the CT scan. Okay, that completes the 2 posterior most implants. They're at full osteotomies, and we can either place the implant at this time or go ahead and prepare the osteotomies in the front. We'll go ahead and prepare the rest of the osteotomies up front. This will be exactly the same sequence, only we're going to change drill length. Now that we've changed drill lengths, we know that our depths correspond with the implant size and length that's been pre-planned on the CT scan, and these can go straight to depth. Place the surgical guide in the drill, keeping it cool. We go all the way down until it stops. Now we're down to our last size on our 3.25 drill. This now becomes part of the color coding. We know that the green ones are a narrow body implant, and so we don't need to go any further with those. Those are complete. However, the blue they're the standard diameter 4-point. So we're going to go one more size on the blue and leave the green alone. And we'll just go to depth on those, here and here. And that completes the osteotomies for all 6 sites. Now we can place our implants. Now, because of our pre-planning and our CT information and the guide and the depth controls and the labeling, so we know which drill goes where and to what depth, we're able to complete our osteotomies in the first little while here, usually about 25 minutes, and we're ready to place implants. And these implants will go in through the guide still. It's still guided. However, it's a passive guided situation, which means I can still feel the bone, and as I place the implants, I still have the surgical touch of knowing where and what dimension the implant is in and how the bone feels. We won't place the implants completely to depth, as we want to do that by hand with a hand torque wrench after we remove the surgical guide. So first we'll place the front 2 implants. This is the narrow body implant. It's a 13 millimeter by 3.3 by Prima. It's a straight implant, and we'll place it right down through our guide. I can feel the osteotomy below, and I look and watch to ensure that I'm keeping my keeping to the right to the middle of my hole. Place me on the implant button. Now I just hold it steady and hold it in the middle. as the implant goes right down into our site. Any section on the implant. We've switched our handpiece over from the 800 to the 50 newtons, and this is the preset for placing implants. Just hold it steady and give it downward pressure so that the implant doesn't have to thread itself into the bone. And there are our narrow bodies. Going into position 4-2 is the 4.0 by 13 implant.
And again, say, I don't put them all the way down because I want to hand tighten them, so just kind of make that point again.
And again, we're not going all the way down to depth, as we want to hand tighten these so we can feel the final position and measure the final torque on the implant. This is important because if I do end up with a loose implant, or one that doesn't have good torque, maybe 10 newtons or even a spinner, say, then I'm not going to want to load that implant. That'll be one we'll want to bury and not use for the bridge.
Next time Jill here is going to be in, she said she's taking a vacation, Dr. John. Would you like to look through that microscope camera?
Okay, our last implant, 8mm. A 4x8 in the lower right back. Here we are immediately after placing the implants. You can see the implants down through the surgical guide. All 6 implants are placed, and we're ready to remove our surgical guide. We just back out each screw. We've finished placing our implants with the surgical guide in place, and now we've removed the surgical guide, and we're ready to take our implants to final depth without the surgical guide. Because of our CT planning, we know how thick the tissue is, and I know that we're going to be placing a 4mm multi-unit abutment on the front 4 implants and 2mm multi-unit abutments on the back 2. Because of that, I want these implants to be down at bone level, so we're going to go 4mm subgingival, which I can measure and mark on the hand tool, and I know approximately where I want my tissue level to be. If vertically we're slightly above or below that, it's okay, because we'll pick that up in the bridge, as long as the implant ends up in a clinically ideal position. and we're to depth now with approximately a 20 Newton force. That's on the low side. Being that we're going to splint these to 5 other implants, we'll load an implant as low as 20 newtons. 30 is probably wise to not go below 30. We've had very good success at 20. And we're right next door to one at about 30 newtons. So we'll continue to hand place these to the proper depth, either the 4 or the 2 millimeter subgingival, and after that we'll be placing our multi-unit abutments. All the implants have been placed to depth, and the torque on each measured and recorded. And we're above 20 newtons on every implant. Most of them are in the 40 to 45 range. And again, we're able to control our osteotomies based on the information we gain from the CT. And we know if there's soft bone where we fell short on the osteotomies on purpose with smaller holes, and that helps us pick up that extra torque on those implants. So now we're ready to put in the multi-unit abutments. We know our depths, and so we have these preset for each position. And this one will go right here and should fit just fine. Okay, let's go right around here to 3.2. It's a 4.0 by 4 millimeters. Now that all the multi-units are placed, we'll give them a final torque of 20 newtons.
There you go, that was better. I was thinking all 6 of those are from different companies. They all got different torque rates.
With the implants and the multi-unit abutments in place, now we get to try in the bridge and the bridge carrier. And we get to look right down through our holes there, and we see if we're lining up properly. So far everything seems to be in good shape. So we're ready to place our abutments on top of our multi-unit abutments that'll be used to attach the bridge to the implants. Here we see the titanium abutment which will be used and the screw to hold it in. We're going to place these first abutments with the short screws because the patient, Gary, he needs to be able to bite all the way down into normal occlusion. And we don't want these posts sticking up beyond the height of the bridge. We also want this titanium abutment to be passive through the hole. So we're going to try it in first and make sure that it doesn't touch the bridge anywhere. I feel like we're touching slightly right here, and so this area on the bridge needs to be relieved. It's questionable whether it's touching or not, but error seems to multiply through any situation, as you know if you've ever done dentistry before. So we're going to make sure that this is passive. Little adjustment. In this stage of the game, we're now just working with acrylic. We have no flap. The surgery site's completely closed. We don't need a sterile environment for this, and this can be done in the standard operatory, dental operatory. So here's a situation where, depending on the dentist, either you can continue at this point and fit the bridge, or if you're working as a team, the oral surgeon at this phase is going to step out. The patient may even travel a short distance to his dentist's office to have the bridge placed. now we can see 100% passive fit on that abutment. Let's go ahead and place the other front one. During the planning phase, we're able to see that which implants are parallel to each other. So in this implant software, I know that those front two implants are fairly parallel and have good draw. Because of that, we're going to use 2 and do 2 at a time here and put in 2 posts. You can do just 1 post and pick it up, or you can do 2 at a time. More than 2 at a time is doable, but it starts to get challenging, so we'll keep it simple and stop with 2. And again, right here, just a little bit of a tight spot right there. Again, it's questionable. It's pretty passive, but I'm just going to take a touch off the side of that acrylic. Now with our abutments in place and our bridge adjusted for a passive fit, we can now have the patient bite into the bridge. Go ahead and bite, Gary, for us. To check our occlusion, and tap, tap, tap right there. And we can see that the bridge gives a little bit in the bridge carrier and allows that occlusion to balance and holds the bridge in its proper 3-dimensional position. Once we open, we'll put our acrylic in around the abutments, and before it sets, we'll have Gary bite into his normal bite, and that will set in its proper position. We've applied our triad bonding agent for our acrylic on the inside of the bridge, and we're ready to place the bridge. Everything's dry and clean. The abutments fit. And we have a dual cure acrylic so that it can set after he closes his mouth. Holding the bridge in place, I apply the acrylic around the abutments on both teeth. And then, to ensure that I got all the way down, there's holes on the lingual that fit, and we can apply some in from the lingual as well. And you can see the acrylic coming up out of that. We're going to place cotton in the top of each hole to protect the screws. And we're going to have Gary bite into his normal bite until that sets. Stay nice and tight, Gary. So we'll go ahead and cure this as it's dual setting as well. Obviously, we're not getting much light through that bridge. There is metal in the bridge, but hoping some light will get through and help initiate the process. Okay, Gary has finished biting down, and we have our acrylic set. And so we're going to go back in the mouth here and take out our cotton pellets and unscrew these 2 abutments. And the cotton just pops right out, just like that. Just slicks right out of the hole. Nice one piece. Okay, when we unscrew those 2 screws, the bridge comes loose. Okay, so now that the acrylic's set, we've unscrewed the screws, the abutments. The abutments come up in the bridge. They're part of the bridge now. And we can remove the bridge from the bridge carrier. And they separate. And now we can take the bridge carrier, and this can go in the trash can. And the bridge itself now has these 2 abutments to hold it in position. So if we take the bridge alone now and place it back in the patient's mouth, and tighten these two screws down, we'll find a very tight, solid, three-dimensionally correct fit on the bridge. Bite together, Gary, in the proper occlusion. Okay, go ahead and open. But I'm not going to tighten those down yet because we want to pick up the other 4 abutments. Now we're going to switch, because the patient doesn't have to bite down anymore to pick up the three-dimensional position in the bite. I'm going to use a long post screw instead of the short screw for ease of use and to protect the inside of this from the acrylic. And again, just like we did in the front, we have to make sure that we have a passive fit and that the front 2 go right down on the bridge. If you look in here real close, you can tell by the feel of it that we're not quite down all the way and that we are binding a little bit in this area right here. And so again, I'm going to relieve the bridge in that area just a bit. Okay, now we've refitted again, and now we have a passive fit here. I have a good solid fit in these 2, and be careful of these little screws, they're easy to lose. We rinsed it out, and so we'll just put that right back in. Just at finger tightness, we're back in position, and we know this is passive. We're ready to add the acrylic again. We've picked up the next 2 abutments with the long screws, and now we will remove those from the mouth, and we have 4 of the abutments picked up. We'll pick up the last 2 in the last pickup. Next step, after we've picked up all of our abutments, we're just going to go ahead and place the bridge for its final placement and occlusal check. So now, instead of the long posts, we'll be putting in our short implant screws. Okay, with all the screws in, we're going to finger tighten for now, as for the first 6 months or so we may need to remove the bridge. And with finger tightening, we'll place a little cotton to protect each screw, and then we'll cover the holes with a temporary filling material. This is just composite to temporarily fill these holes. It's real easy to remove with a carbide burr and down to the cotton, and then so we keep access. Everything's sealed and ready for occlusion. And that completes our case for the day. We have utilized the smart implant system today, and it has allowed us to use the great planning of the CT all the way through to the smart bridge and the smart carrier. And we've done it in about 3 hours with the teaching time with the cameras. In a normal procedure, that would go a little bit quicker. And we've done it flapless, which means that Gary gets to go home tonight with 3 Advil. Depending on the patient, we may even give some Medrol. Although in this situation, I think we'll expect very little discomfort. He's been through this procedure before, so we know what to expect. And we've been able to take all the advantages of the CAT scan: better bone, bigger implants, safer procedure, flapless. It went very quick today, so faster for the patient, faster for us, and a well-balanced occlusion that was put into place with the smart carrier and the smart bridge, allowing us to have a good, balanced, predictable occlusion placed on the implants without any torque or pressure translating down into the implants. So that gives us our complete final product as planned. Everything went well today, and that's it. Thanks.